right, that was a background report by Bassey Itayekman. Thank you, Bassey, for that report. Now, that cough, yes, that cough, if it be TB, not COVID, go check them. Well, that is our localized slogan for this year's World TB Day already. The global slogan is, "The clock is ticking." And to further shed light on this very dangerous and fatal disease in Nigeria, we have our guests seated here in the studio, and I'll start with Dr. Chukwuma Anyike, who is the Director and National Coordinator, National Tuberculosis and Leprosy and Buruli Ulcer Control Program at the Federal Ministry of Health. Dr. Anyike, thank you very much for joining us.
Thank you. Good morning, Nigerians.
I also have with us Dr. Moni Amos. Dr. Amos is the National Professional Officer for TB/HIV at the World Health Organization, WHO Nigeria. Dr. Amos, thank you very much for joining us.
Thank you. Good morning, Nigeria.
All right, joining us from Kano studio is Professor Isa Sadiq Abubakar, Center for Infectious Diseases Research, Bayero University, Kano, and member of Kano State Task Force on COVID-19. Gentlemen, it's a pleasure to have you join us this morning on Good Morning Nigeria as we discuss this very dangerous and infectious disease. But first of all, Claire, I think it's important that we get to understand what tuberculosis is in the first place, and what nature of disease are we talking about here. And so let me bring in Dr. Chukwuma Anyike, Director of National Coordinator of National Tuberculosis and Leprosy Control Program, Federal Ministry of Health. What is tuberculosis, and what nature of disease are we talking about here?
Yes, tuberculosis is a respiratory infection primarily that affects the lungs, and if not treated on time, it could disseminate to other parts of the body. It's caused by a bacterium called Mycobacterium tuberculosis. It was first discovered in 1882 by a very strong scientist called Robert Koch. I think initially it was being Koch's disease. And so it could be transmitted from one person to the other, just by coughing or sneezing. That's why it's, we tell people to enjoy this etiquette of coughing through, on your elbow and covering your nose with your handkerchief, and then doing personal hygiene. So it's highly infectious. It's one of the worst bacterial infections that's, if not taken care of, it can lead to high mortality. So it's ranked, the worst of the bacterial infections, and Nigeria carries a very significant burden globally. Nigeria, in fact, is the first in Africa and the 6th globally. So, and as a national program, we are doing our best to make sure we curtail the menace of tuberculosis. It's very important to know that the infection affects mostly people at the productive age, 15 years to 14 years. And then if you come into a nation where that critical mass of people are affected, that means we'll be having a problem of our developmental milestone in terms of economy.
All right, thank you, Dr. Anyike. Let me bring in the Dr. Amos, who is of the World Health Organization. I'd like for you to talk to us within the context of the global slogan, the clock is ticking. We already know that the clock is ticking. And within our own localized slogan as well, that cough, fit be TB, no be COVID. So what's the global conversation?
Yeah, the theme for this year, what TB Day is, the clock is ticking. The clock is ticking was adopted because it's a call for action. Call for actions for political leaders, call for actions for community leaders, call for actions for people in the community. In terms of the call for actions for the political leaders, in 2018, there was this first United Nations high-level meeting to end tuberculosis globally. and the leaders of various countries made commitments. Nigeria, including our president, our dear president, President Buhari, made a commitment at that meeting. And the whole leader came together to say that they are going to diagnose and treat 40 million people for tuberculosis. They are going to ensure that 30 million people have access on preventive therapy. That was the commitment made at that meeting. And based on that commitment, for us in Nigeria, we are supposed to diagnose between 2018 to 2022 about 1 million people, over 1 million people, and place them on TB treatment. We are supposed to put about 2 million people on TB preventive therapy. 2022 is 2 years to go, less than 2 years to go. Where are we with this? For us in Nigeria, we are still far away. And that's why the clock is ticking. It's reminding our political leader, you made this commitment, please do everything possible within your means, provide the needed resources so that this target could be achieved. So it's a reminder, a call for actions for all political leaders at the federal government level, at the state government level, because these targets are also disseminated to each state to say, this state, this is what you are supposed to get.
What's the gap in the commitments made, between 2018 and now, for us specifically?
Okay, if you look at if you look at the total, like 1 million people to be placed on TB treatment, so far we are like at 32% of it. So which means if you continue that way, at the end of the day, we might not reach 50% of it, right? So it's still a lot of gap. The major gap, the huge gap, is in the preventive therapy. And that's less than 10% of that has been achieved. Less than 10%, even less than 5%. So we need to scale up action. We need to provide because the know-how to do it is there. The government, the national program has a strategic plan that gives direction. Now we want to achieve this from 2020 to 2025. There's a strategic plan. The major challenge is the funding gap, which need to be addressed so that we can effectively scale up these services. And like I was saying, it's also a call to actions for community. You don't have to wait. When you see somebody coughing, and you don't have to wait for a condition to degenerate. Each day, the clock is ticking on that person that had tuberculosis that refused to come for treatment because they get worse day by day. And if they presented late, that's why we have dead in tuberculosis. You're not supposed to die. So for the community leader, it's also a call for action. For community people, it's also a call for action. When you see people that are coughing in the community, ask them to come to the hospital. Ask them to go to the facilities. We'll test them and see if they have tuberculosis. And if they have tuberculosis, they will be treated and provided the right treatment.
Before we bring in Professor Issa Sadiq, when we talk about bringing people for treatment, of tuberculosis as a disease, is it all hospitals that have the facility or the necessary medication to treat tuberculosis? Because I understand that there are specific hospitals for tuberculosis treatment because of the high infectious nature of the disease.
Yeah, thank you. It is for now. It's not all hospital, but the plan, because we are working towards achieving the universal health coverage target of ensuring that all facilities are providing one form of tuberculosis services or the other. But we have over 17,000, almost 18,000 facilities across the country, both in private, both in public, that have these services free of charge, right? And you can get information from these services, you can get your services, your treatment from this facility. And this year, we are adding another 5,000 facilities to it. So effort is being made to ensure that all the facilities in the country have access to it. But there is no local government without a facility that doesn't have it. There is no general hospital that doesn't have it. There is no teaching hospital that doesn't have it. These services are there, and people should access it. So we are scaling up to all primary health care facility now, and we are ensuring that they are covered. Okay,
let's bring in Professor Issa Sadiq Abubakar from the Center for Infectious Diseases Research, Bayero University, Kano. And he's also a member of the Kano State Task Force on COVID-19. Professor Sadiq, good to have you with us. The statistics we get from WHO puts Nigeria #1 in Africa with, high burden of TB, and #6 in the world. Now, that makes Nigeria really, really burdened country in terms of TB, cases. Which part of Nigeria would you say is endemic?
Tuberculosis is a disease, mostly initially we used to say it is a disease of the poor, but now it cuts across all socioeconomic strata simply because it has to do with immunity, and you know that we have people with loss of immunity across the country. Actually, it is a disease that is widespread, and there is no single part of Nigeria that we can say is spared from the infection. So it is actually a widespread disease, which we can actually say universal in the whole country. And of course, the National TB, Leprosy and Borrelio Ulcer Control Program has statistics revealing where the burden is high, but then in a nutshell, we can say that it is widespread, touching on different parts of the country.
But where do we have a high burden? Which part of the country is high burdened? I mean, we must know which area, is has high cases of TB from your research.
Yeah, as I was saying, that there are, of course, different states have different level of prevalence of tuberculosis, but then you cannot say that all these states are in one part of the country, whereas the other parts are not touched. But we know that, like most of the diseases, states in the northwest and northeast geopolitical zones, because the disease actually, to a large extent, is also associated with poverty, and so these areas are bedeviled by high amount of poverty, not because the infection is restricted to this area, but mostly control of the disease, as we all know, is more on these parts of the country compared to other states in Nigeria because of high rate of poverty and ignorance. Because it is a disease that requires awareness, it requires people to take action, and where these two factors, poverty and ignorance, are highest, of course, are more burdened than other parts of the country.
Right,
Poverty. Sorry,
I
what?
want to take him on this aspect. Understanding the biological behavior of the disease. I'm talking to Sadiq Abubakar. You are of infectious disease research. Are there different strains of tuberculosis? If there are, what has research been able to prove in terms of understanding the strains of tuberculosis? Because that will also make it easier to find a cure or the kind of medication required to treat the strains of tuberculosis, if there are two.
Well, actually, tuberculosis is caused by a bacteria, as my colleagues have earlier mentioned, called Mycobacterium tuberculosis. Of course, it has different variants, but then most of them are amenable to treatment by the drugs that are currently in use under what we call directly observed therapy short course, that is DOTS. They are effective drugs that take care of most of these drugs. All that people need to do is to avail themselves to a particular health facility that provides these services. Having said this, however, we know that some of the cases are what we describe as multi-drug resistant tuberculosis. These are the types of tuberculosis that do not respond to the conventional therapy, but they are not as large as the normal ones, but they are very dangerous because the normal drugs that we use in treating patients with tuberculosis cannot take care of this. So once this is proven, and in most cases we have to do more tests than the ordinary tests used to diagnose, because people ordinarily will have to produce sputum from their cough, and then this is taken to the laboratory for us to test using mostly the machine we call gene expert machine. And then it shows the type of bacteria, I mean the Mycobacterium tuberculosis. And so if it is proven that it is multi-drug resistant type, then the treatment requires the person to be isolated, and even the health workers have to be with the patient under strict cover because they have to use personal protective equipment, popularly called PPE. And then the drugs that are used, we have to bring in other types of drugs, second-line drugs, not the ordinary type.
Okay, I'm still staying with you, Professor Sadiq. You talked about isolation of TB patients. How contagious could it be? And apart from poverty and the status of or living condition, are there other dispositions that could exacerbate the condition?
Yes, especially for those of us that are living in this environment, we are exposed to tuberculosis almost every day because it is widespread in our environment. But then why are we not having tuberculosis? This is because for most of us, we have natural innate immunity in us, but then for some reasons, some people will lose this immunity because in early childhood, most of us have been exposed to it and we are able to contain it because our immunity is good. But for people who, for whatever reason, have lost that immunity, for example, malnutrition, because people who are malnourished have poor immunity and then they are exposed to this highly contagious disease. Similarly, people who are exposed to infection, opportunistic infections, for example, HIV/AIDS, make people to lose their immunity, and these people easily contract tuberculosis. And then people who are using certain drugs, for example, what we call corticosteroids, these are drugs that dampen the immunity and exposes people to the risk of contracting tuberculosis. And there are other factors that have to do, I have mentioned that earlier, poverty and ignorance. But then living with a person that has tuberculosis for most of the time, and if care is not taken, the people in the neighborhood of such a person are also liable to getting the disease. But then of equal importance, or even, let me say, very, very important, is the immunization that is given helps to protect us from tuberculosis, apart from the natural exposure. It is expected that children who are being born, during birth, they should take the immunization that is called bacillocalmette guerin, or commonly called BCG, to protect them. So people who are not immunized against it are equally exposed more than others. So these are some of the factors that are associated with the disease. And of course, people who, for whatever, if people are smokers, for example, they help to reduce the protection they have against all sorts of infections that affect the lungs. And of course, tuberculosis is one disease that commonly affects the lungs. And so smokers are more liable than others because we have some protective filler. I mean, in our respiratory system, we have something that looks like hair that tries to prevent infectious agents from getting into us and causing serious infections. But those who smoke they destroy this covering. And then the infection, the bacteria now finds it easier to enter the lungs and create havoc. So these are some of the factors.
All right. Thank you indeed. And certainly we'll return to you in the course of the program. Meanwhile, let's return to Abuja studio where we'll still have Dr. Chukwuma Anyike, Director, National Coordinator, National Tuberculosis and the Leprosy Control Program. Now, Claire earlier asked the question of which are the areas that are more endemic, right, in the country. And I want to ask you this because being the national coordinator, you could be more disposed, with information regarding the spread of the disease across the country. So which area of the country will you say that this particular disease is endemic, and what is being done as a national coordinator, what is being done to, increase awareness campaign in these areas to sensitize the people on this particular disease, which of course, for so many years, as I said earlier, Claire, that people don't talk about tuberculosis anymore. It's as if the disease does not exist anymore. Meanwhile, the disease is there. Even with the COVID-19 that we had since 2020, we still have tuberculosis. And people are even asking the question, is there any correlation, between this tuberculosis and of course, COVID-19? Because they're all respiratory diseases.
Yeah, thank you. Let me start by saying that in naming a particular state or a particular region as being the highest burden, we need to consider certain things. For instance, the drivers of the infection. I do know that Lagos, because of the congestion, especially the urban slums, are most likely going to have a lot of them. You also get to maybe in some states, because we're able to group the states according to the HIV burden. We also know that HIV drives tuberculosis, and tuberculosis, both of them work together. So you're most likely going to have those problems. Then when you talk about the areas that due to poverty are mostly going to have it. Like my colleague said, we cannot say a particular, because every part of the country is affected. And when we are programming, we go to every part of the country. We are working with the National Orientation Agency. We are also working at the grassroots, because we have also noticed that one of the drivers is stigma and discrimination. People should know that this disease is preventable and is curable as long as you take your treatment. Most people that are exposed to that, due to stigma and discrimination, they will take the drug for a while and they wouldn't come out. And in that process, they keep spreading the infection in the neighborhood, and that becomes a problem. So in terms of awareness, that is why we do not even wait until it is World TB Day. We do our best to make sure we get to the grassroots, talk to the people, use the mosque, use the churches. And that was why we came up with that slogan, that cough. Because we noticed that last year, the COVID-19 pandemic caused a lot of, destruction in our socio-economic. So most people were avoiding the hospital, because if they cough, they think they will be isolated. And we said, no, that cough may not be COVID-19, it could be tuberculosis. So that we do not run away from something we can treat. We have the drug. If you take it within the specified duration, you'll be cured. And our own drive is to cut the chain of infection. Because if you get it and you are not treated, you stand the chance of passing it to your neighbors, whoever that is taking care of you, and it becomes a snowballing effect. So we feel that if we're able to get the person diagnosed, placed on treatment, will cause the chain of infection, and that will help us to reduce the burden in any part of the country.
Dr. Anyedike, I'm just curious. The TB survivor, in one of our respondents in the excerpts we saw, told us that, look, the TB treatment is available, it's accessible, and it's free. And yet here we are, we being Nigeria, having the highest, we are the first in Africa. We are number 6. What is it that is driving people away? Why are people not coming out?
Well, you also know that in this part of the country, we have a poor health-seeking behavior. Someone will be sick, he will think, let me just take paracetamol. And he takes paracetamol until when the disease has crippled the person that you can't do anything, the person now remembers. In fact, it's the neighbors that will not take the person to the hospital. So our poor seeking behavior is an issue. Then poor awareness, knowledge of what the signs and symptoms of tobacco is also another issue. Do you understand me? Another one is out-of-pocket expenses. Several people maybe not even have eaten, and they're having this cough or they're having this feeling of unwell. It will take them time to go to the hospital. Do you understand me? So out-of-pocket expenses is an issue in the country. But beyond this, everything is available. It's just for them to go to the hospital and you'll be screened. If you're positive, you're placed on treatment. The drug is free.
If people are at this stage, if Nigerians are at this stage, say ignorant of the symptoms and signs of TB, is it a function of communication, poor communication strategy, poor awareness strategy, lack of it, or approach? Is it a problem of approach, in control methods?
I think it's multifaceted. All these things come into play. One is the knowledge. 2 is the inability to be able to go to the hospital. 3, that attitude of thinking that I will be all right. The next one is the stigma and discrimination. But beyond this, we are telling everyone that if you have any sign of this, you go to the hospital. There's something about tuberculosis. It doesn't come with a high fever. It comes with low-grade fever. Quite unlike COVID. COVID comes with a high fever. Tuberculosis comes with a low-grade fever, feeling of unwell, and then they cough. Some people, when they have the cough, they wouldn't go to the hospital.
That's what I'm asking.
Yes.
Is the I don't want to use problem. Is the issue now that of the approach that you use, Ministry of Health, those under the TB and Leprosy Control Unit? Is it that you have not been able to reach out in terms of awareness? You have not communicated effectively, to people what these signs are, so that when they cough or when they see any of the signs, they realize that, oh, look, this must be TB, or this could be TB. I have the need to go to the hospital. Have you done your work effectively in communicating these symptoms?
We have done this, but just know that it's a process. Like last year, even with the presence of the COVID-19 pandemic, we were able to notify 17,699 new cases because the information is going out. But we felt that we should continue. That is why we call on everyone, especially the information using the print and the electronic media to let people know. It's a reminder. It's not just a one-off process. We keep making that information go around, and that will make people to come, and then that will make even your neighbors, when you cough, they tell you, please, can you go and check this cough? That awareness, not only for the person, for every person that is very close to you. If you cough for a lot of, please, can you go and check this? And with that, the number is increasing. So it's not a one-off issue. It's a continuous process.
Dr. Anyike, I think why Claire, persisted with this question of sensitization is the fact that if not for the World Tuberculosis Day, nobody gets to hear about tuberculosis. Nobody gets to hear about tuberculosis for a while now, and being so contagious as it is, it's even more than just like COVID-19, from all indications. Because if people are not aware, and people keep coughing and keep passing the disease from one person to the other, then of course it's more dangerous, and of course it's killing much more people. These days we hear about the strange diseases coming out and killing a number of people within a space of time, and we don't get to know why. It could be tuberculosis. That is why perhaps the question of the issue of sensitization is key. And I want to bring in the WHO man here. In fact, we rely on WHO when it comes to health matters globally. All right. Then, what specifically has this organization done in Africa and Nigeria in particular with respect to what I should call a war against tuberculosis? What input has WHO made in terms of provision of whatever is necessary to fight the disease?
Okay, one of the I'm going to take it in series to tell you what we have done, and also I will add some things on the question you're asking. But I'll start with the WHO question. One of the things we have done as WHO as a body is to work with our member states to put down, to develop strategies that can help in ending this epidemic. Right? We have what is called now we have what is called NTB strategy. Right? That's the strategy that came off post 2015. So we help in developing strategies, and like these NTB strategies as a pillar, 3 pillars, as principles, as some elements. Right. First, I can talk about the first pillar is talking about integrated patient center, TB care, and preventions. The second pillar is talking about both policy and supporting system, and that's where the challenge is, which I'm going to talk about. And the third one is talking about innovations, intensifying researches and innovations. Right. So I will use that second pillar, for example, to answer your questions. The both policies and supporting system if you look at the first element there, it's talking about resources for TB control. The problem with the question you ask, why people are not aware, is that the investment is not there. The investment on awareness creation is not there. Look at HIV. At the beginning of HIV, there was a lot of investment in HIV, in ACSM activities. You open your radio, you hear something about HIV. When you are small, you know about HIV. So the investment is minimal, right? And like now we are having dwindling funding from donors. A lot of things is happening to the economy. So people are investment. They are now prioritize some aspect of it and not investing on that area. And that's why that's both policy and support system is very, very important. We need to invest. There was something we call knowledge, attitude, and practice survey that was done in 2017.
Sorry to cut you on the issue of investment.
Yeah.
We keep blaming funding, investment, finance, and all that. Nigeria, according to WHO, recorded 15% new cases in 2020. And I want to believe that much of these people live in the rural areas. How much investment do we need to sensitize people in the rural areas? You have traditional rulers in the rural areas. You have even the traditional methods of, passing information. How much of investment do you need, to get these people, this information passed?
So when I talk about investments,
yes,
I'm not talking about only funding. Investment in engagement of policy leader, right? Investment like the national program. We have what is called the Stop TB partnerships, right? That is also being established at the state level, and we have what is called engaging even the wife of the governors in all the 37 states. The aim is for them to help us pass this, right? But we need this kind of investment along the line. We need the resources. We need people to be really, really engaged as champions in passing this information around, right?
Now that you've mentioned wife of state governors. I know that, was it in 2018 or so, the First Lady of Nigeria was made the TB champion. And I know the First Lady of Cross River State also is a TB champion. How much collaboration have you been able to work with them?
Yes, we have been working with them. I think even during the World TB Day, we during the press briefing, the First Lady came with, I think she sent someone to attend. And then I think last week we reached out to the First Lady of Kwara State. We are through the Stop TB partnership, we are making a one-on-one interaction with them.
Because he's talking about investment of press. That's why I'm asking.
Yes. So we're making a one-on-one interaction to them. Also to know that, it's like a husband or a family that has multifaceted problems. So we need to put in more energy in trying to remind that we are still here. So with the system of establishing trustworthy partners in the states, that will keep tapping the wives of the chief executives of the states. That's what we are doing at the moment.
In appointing personalities as champions of a cause,
yes,
are there objectives? Are there targets? Are there responsibilities to that position, that office?
Let me liken it up to what he said. Because we cannot run away from the fact that you need resources to do some of these things. It may not just be a political statement, but there must be that backup, that physical something that will be able to make people to go. Let me also add to the first question you asked. At the moment, you're working with National Orientation Agency because they are the grassroots. But what I'm saying is that with the effort we are making, and that's why we continue to make the effort, we're not thinking of stopping even after the World TB Day. We'll continue to make that impact. It has to do with behavioral change. People will get sick, they will not go until someone comes to muzzle them to go to the hospital. So attitudinal change is something you must be able to preach. The survey that was done 2 years ago showed that 27% of people do not even have the attitude to go to the hospital. So in as much as we are putting off this mechanism, we also talk about behavioral change, which is very important, it's key. The wife of the governor cannot force any person that is sick to come to the hospital.
You must also consider the out-of-pocket. You mentioned
that's what I mentioned. So there are a lot of factors. It's not just one.
Earlier on, if I had it right, that you don't need to pay for tuberculosis treatment. How true is that? Do you pay for it?
You don't pay.
Good. Now, how many hospitals, that handle tuberculosis are prepared to treat somebody free of charge? Because is there any monitoring mechanism to know that any tuberculosis patient, patients are not charged?
Let me tie it to, because I know why you asked the question. When we are working in a referral system, we have up to 40,000 health facilities in the country. And we're able to be able to activate 17,699. So we still have a very huge gap. But there's no local government that does not have, a dot center. But that fund to move from one place where you are referred to the other is a factor. That's why I said out-of-pocket expenses. But if you walk yourself into that health facility, you get the diagnosis done free, and you get the treatment done free.
Okay, so I'm still going to, sorry, Kirian, I'm still going to bring in the WHO, because when WHO appoints people as champions for a cause, is it a mere political appointment, or is it attached with responsibilities? Because you're talking about investment of people.
Yeah, there are, before even the engagement, there are what is called the terms of reference, right? And the term of reference also guide you on the kind of people you choose, right? And that's why the wife of our president was chosen. So there were terms of reference, right? For example, he has helped, even outside Nigeria, he has helped pull all the wife of the president of all the nations together and push this, right? And to our credit also, he has brought the 37 state governors, the 36 state and FCT wives together last year, right? And, made them also a TB ambassador in their state, right? With clear terms of reference, right?
I know the Kwara State governor's wife is also a TB ambassador.
Gentlemen, it's not as if efforts are not being made. But whether the efforts are impactful, that's another aspect. Because if Nigerians are unaware of even, the common symptoms of tuberculosis, we'll have normal cough. Not COVID-19, normal cough where we have, perhaps sometimes seasonal changes, we have some coughs and stuff like that. Now, how does an ordinary person understand that this particular cough is beyond the normal cough that could lead to him going to hospital? As rightly said, we have a behavioral pattern whereby we rely on self-medication so much. Perhaps because if you go to hospitals, you have to go through the rigors of being treated in the hospital, carry out tests and what
Selling that is COVID-19.
Exactly. And you talk about out of the pocket, expense that is, of course, biting. So the issue here, if I understand what we're talking about, is how to get Nigerians understand what tuberculosis is. When you have symptoms, are you able to know that, look, this one is beyond this cough is not COVID-19. Perhaps let me go and check if it's tuberculosis. That's what is missing. But the awareness creation is what I believe is not there. So let's get Professor Sadiq coming here. Professor Sadiq Abubakar, you've been listening to your two other guests, speaking on the issue of sensitization, on the issue of having enough funds, financial muscle to push, tuberculosis and get Nigerians to understand what it is and how to react when you have some kind of a strange cough. What is your own take?
Yes, actually, you see, in Nigeria, or at least some laudable programs, we have them on paper. When you are talking about policy, when you are talking of plans of action, they look very beautiful. But implementing them, because as they have been saying, requires a lot of resources. It's like we choose certain aspects and to a large extent we neglect certain aspects, and these are equally as important. What I mean here is when you are talking of the reagents, the equipment, and the structure or infrastructure we need to make diagnosis and to treat patients and to provide the drugs and consumables, we are doing very well in that, because as far as a person will get to the health facilities, be it at the tertiary level, secondary or primary healthcare level, or even the private health facilities that have been chosen under this program, you may not find much problems except for some stockouts that are not even mainly significant. But the aspect of prevention, for a long time, we have not been investing much in that. And of course, awareness creation, social mobilization, these are aspects of prevention, because the more people get aware of the dangers associated with the disease and the actions they need to take as individuals and as communities to fight this disease is suffering, because we are not investing in that. And of course, I personally feel that we need to look at this aspect just as we are doing well in the area of providing facilities for diagnosis and treatment. Because the more preventive measures we take, the more likely we are to have fewer cases. But of course, the aspect of social mobilization and awareness creation and risk communication, community engagement, these we are not doing as well as in the other aspects. And we need to do more.
Just before we take our break, Professor Sadiq, I'm still remaining with you, and my next question will be standing on the tripod, which means I have 3 questions. The first one is, first of all, you talked about BCG at birth. Does having that confer immunity against TB? And will is TB, that's tuberculosis, an indication of an onset of other immunodeficiency diseases like HIV? Is it an onset? Is it an indication of an onset? And then the last one will be, what is the behavior of a COVID-related cough? How is it different from a TB-related cough?
Thank you very much. BCG immunization, of course, through researches, have been found to protect children from the infection. And that is why you find out that in our national program, we have a routine immunization program, we have BCG being given to children as early as possible after birth. In fact, it is expected that even before relatives who come to congratulate the couple that have produced this child, the child should be given BCG immunization. Because among these people, of course, there are a number of people who might be carrying the bacteria with them, and coming to interact with this baby, they may serve as a reservoir of infection that will transmit this bacteria to the child. So BCG is an effective mechanism for protecting people. And even if a child does not get BCG vaccine at birth, we still expect that the child or the person should still take BCG vaccine, because there are some people who, for one reason or the other, have not been given the vaccine, and then in their adulthood, when they are tested, we do a test called Mantoux test to find out if these people have the level of protection that is needed, because some will naturally acquire the protection by simply living in the environment where TB is prevalent, and then they may get some of the protection. But then many will not have, and then they have to take BCG immunization at a different dose level, of course, because of the exposure they have had. Now, the second question has to do with, I think, well, it has escaped my memory. The second question, if you can remind me, I will take us on that, please.
I said, is TB an indication of onset of other immunodeficiency diseases? That's the second question. And then the last one will be the behavioral difference between a COVID-related cough and a TB-related cough.
As I said earlier, tuberculosis is an opportunistic infection. That is, opportunistic infections are infections that ordinarily, if we have our level of protection, they will not have a place in our bodies. But then, if for whatever reason we lose this immunity, and of course, immunodeficient, like HIV/AIDS, that is acquired immune deficiency syndrome, the people lose that natural immunity in them. And the bacteria, which is looking for an opportunity to get into a place where there is no immunity, will now come out. So it is not like it is what causes the immune deficiency, but its appearance in some cases will now give us an idea that this person's immunity is low. And that is why if you get to any treatment facility where people are diagnosed with tuberculosis, you cannot separate it from HIV, which is commonly known to now expose the people to this infection. So the test for HIV is also given to them. So in some cases, so your question, we can say that it is yes and no, because it helps when you diagnose tuberculosis and alongside you carry out the HIV test, it helps to indicate the presence or otherwise of HIV, which is an immune deficiency disease. But of course, because not all cases of tuberculosis as a result of HIV, then one can say that it may not be one-on-one thing, because there are other causes of immune deficiency. For example, even people who have cancer, they lose their immunity. People who are on long-term treatment with some drugs that we call corticosteroids, and then some other causes like malnutrition and other causes of immune deficiency expose the person further to tuberculosis. Then, regarding the differential in terms of presentation between COVID-19 and tuberculosis, you see, COVID-19 is an acute illness that comes with high-grade fever, like my friend has earlier mentioned, and if cough is manifesting, then it is mostly dry cough, and whatever havoc it is wreaking is acute. It doesn't last long, whereas tuberculosis is associated with low-grade fever, and then it is chronic. It lasts for a long time. And so it is possible for you to differentiate the cough of COVID-19, which in most cases will cause the infection, the fever, the cough, and if the person's immunity overcomes the disease over a short time, then the person will overcome COVID-19 in a matter of maximum some few months, like 2 months is enough for a person who will ultimately overcome the disease to recover. And in most cases, it is even much lower than that. You know, we used to say that after 10 days, usually the person is not even as infectious as earlier. And so this person, and that is even the reason why people that can not, I mean, it's not in all cases that they must go to the isolation centers. If they can isolate themselves at home, they can be treated at home. Whereas in the case of tuberculosis, which lasts long, which may last for a long time, it is taking a chronic course, and in its case, when a person coughs, it sometimes is associated with, I mean, in most cases, it is associated with sputum, that is bringing out something like mucus from the lungs, not like the normal mucus that comes out of our nose. And then, in some cases, this mucus is associated with blood, and it lasts for a longer period. And of course, it is not a disease unlike COVID, that the person may overcome it naturally, because it is a virus, it is a self-limiting infection. So people who will ultimately get over COVID-19, and they are the majority, will get over it, as I said, within a short time. Whereas for tuberculosis, if nothing is being done, it continues until sometimes it leads to other complications. Like Dr. Aneke mentioned, it can spread to other parts of the body, and then it causes disease in those other parts, because it is not only the lungs that is affected. And even in the lungs, it may even lead to lung collapse, and the lung may not be able to take in oxygen, and the person may die from respiratory failure. So other parts of the body, from the brain, because there is what we call tuberculosis meningitis, the covering of the brain may be affected, and then the person may have meningitis, and he may die from it. And then the kidneys are not spared, because even our vertebral column may not be spared. And so when TB eats up the vertebral column, which gives us our posture, the person may even get paralyzed from it. And then even the abdomen is not spared. We may have tuberculosis of the abdomen, and then people will have problems in their, what we call ordinarily stomach, that is the abdomen in medical terms. and then they have a lot of problems to do with eating and being able to process the food they eat, and that may cause severe problems in them. And in fact, we can have disseminated tuberculosis that spreads to wide area in the body, and that is also a big problem. And so tuberculosis is a very dangerous disease that affects multiple organs, and it lasts long, and of course, it leads to a lot of complications in the person. But the beautiful thing about it is, if we are able to diagnose and offer the treatment, and the people become adherent to the treatment, then it is a disease that will go after completing the complete course of therapy, which in most cases, in the case of the uncomplicated tuberculosis, may last about only 6 months. And in some cases, when we use other combinations, it may even last shorter than this period.
We're actually learning a lot about this very disease. We thank you for that analysis coming from you, because the question from Claire actually led to real analysis of what this disease can do, and that's why we are talking about sensitization of Nigerians on this very dangerous disease that we have been living with over the years. I think when we return, we'll also like to find out whether there could possibly be a vaccine for tuberculosis, just as we have vaccine for COVID-19 at the moment. Whether it's a possibility, perhaps it will come from a research center, And we're glad you're still with us here on Good Morning Nigeria for today. And we're taking a short break now. When we come back, the conversation continues.
I bring you wonderful news. The village headmaster is coming back to your screen. Mo wire abi mi o wire. Teacher no mo, a fẹ́ lọ wá nǹkan jẹ. Teacher no mo, a fẹ́ lọ wá nǹkan jẹ. Ọmọ onírẹsì ti dé.
Ajebo na better school for last gidi. Not be all this on a rugged school for Ijabi. I don't know for you.
Second, it's called Oja Village. Kadesi. We know happy at all.
And I know that even you too, you are getting a lot of orders too. Hey, we are trying, shall. Sweep her leg out. She was standing there. Sweep it.
I love you so much.
And how did I give you the impression that I was interested in that position?
50-year anniversary.
You mean anniversary?
I mean, I talk with that now.
Not for me. You want to make a die? Not for me because of Pamio.
Although social media as a channel of communication is inherently harmless, it becomes harmful and damaging when used without discretion and thoughtfulness. Bad social media users spread rumors and fake news without verification. But good social media users stop, reflect, and verify information before sharing it. Be a good social media user. Stop the spread of fake news. Verify the authenticity of your source and use social media responsibly for a better Nigeria. This message is brought to you by the Nigerian Television Authority, NTA, in collaboration with the National Orientation Agency.
Clear the road for Super Eagles. Hey.
The battle for Cameroon Africa Cup of Nations 2022 rages on. It's Nigeria versus Benin Republic in Porto Novo on Saturday, 27th March, with the second game against Lesotho coming up on Tuesday, 30th March at the Tesla Balogun Stadium, Lagos, live on the network service of NTA. Kickoff is 4:30 p.m. for both matches. Take advantage of this great opportunity and partner with us. For adverts and sponsorship, please contact Bola on 0803 7044 286, Hawa 0803 3121 022, Betsy 0803 3324 328, or Tayeige on 0803 7000 799.
From Samuel to get in on goal, slips his way through!
Don't be left out as the Super Eagles fly over the squirrels and the crocodiles.
Thank you for staying with us on Good Morning Nigeria on this Friday, that we are discussing a very important topic that has to do with health, tuberculosis, and how to end that deadly disease. Dr. Omoni Amos is still here with us. He's of the WHO. I raised the issue of the possibility of having a vaccine for tuberculosis. Well, first, the BCG, which is usually given at birth. And this time around, I am talking about vaccine that could be given to adults. COVID-19 struck the world last year, and within a year or thereabout, a vaccine was produced. Is there any political connotation to this? Because tuberculosis has been with the world for like centuries, and nothing has been done in terms of a vaccine. We may also have to add direct involvement of WHO in terms of eradicating tuberculosis, especially in Africa.
Okay, thank you for the question. Let me start with the vaccine first. Like you rightly said, BCG is the only existing vaccine. And there are a lot of vaccines that are also in the process of being developed, but one has passed to phase 3, which means between now and next year, we might have a vaccine for TB prevention, right? Because it has passed to phase 3. So resources researches are ongoing to have a vaccine for TB, but only one has reached phase 3, right? And hopefully by next year, that vaccine will be out. And then we, especially it will help us in the area of prevention, so that people don't progress to get TB diseases. Also, in terms of what the WHO is doing, we work with our members to ensure that in terms of regimen, for example, the preventive regimen, we have a lot of preventive regimen now that people can take that can prevent them from progressing from infection to disease. Now, if you take it, you don't develop the diseases. So we have what is called there are various forms of them. We have the one you can use for weekly for 3 months that has been developed with support also from WHO and partners. We have the one you can use for 1 month. We have the one you can use for 4 months. Then we have the one you can use for 6 months, depending on. So we have this preventive regimen available so that people now can use it. Like the prof said, whenever you have somebody that has tuberculosis, for example, I can prevent his family members from getting tuberculosis. All I need to do is just to place them on that weekly treatment or the monthly one, depending on the one that is available and they choose from. And they will not have tuberculosis, right? So the contact of TB, can be prevented. So in terms of preventive regimen, we are doing a lot of things in that area. Also in terms of treatment, also, right? For example, in the area of multi-drug resistant tuberculosis, before we use injection, that you have to take injection for a long period. Mm-hmm. Now we have oral regimen that you can use for 9 months, and then you'll be okay. We are also looking at shortening the regimen, because the longer the regimen...
For 9 months?
Right. The longer the regimen, that's for drug-resistant tuberculosis. The longer the people take drugs, it's not easy to take drugs, if you agree with me. Mm-hmm. So we are also looking at how do we shorten this, that within a month, 2 months, people... will get cured. So WHO is working with scientists, and hopefully very soon we are coming up with a lot of regimen that is shortened, that easy, that people can take, like we have done for the prevention. Now there are treatment you just take for 12 tablets, 12 once a week, and you are okay. You are not going to have TB. That's in terms of the regimen. In terms of diagnosis also, right? You know, before we rely on microscope, now we have gene expert. Now there are a lot of diagnostic tools that WHO is being approved. Now we have what is called TrueNat, that it can even be used in the villages, that you can take to the field to make your diagnosis. So we are working towards getting the kind of point of care test that you can use in that area.
What about the availability of those ones we're talking about? The availability in Nigeria, can that actually be used in Nigerian local areas? Is it available?
Like the experts we have in about 401 facilities is available, right? And more, as I'm aware, even this year, right now, additional 100 has been procured. So a lot of investments is going to that area. And we're also looking at, because some of the machine, like you said, the temperature, the temperature, the environment. So that's why we are also WHO is also working with partners to ensure that we have the one that can be used in our environment with the heat and everything. And that's why the government and WHO we are bringing through NATO now that is going to be used. So a lot of things being done in the area of diagnosis also.
Okay, let me also stay on this question that Kieran is asking. Kieran earlier asked you about the vaccine, but specifically his question was for TB. But I'm going to ask you, I know WHO and partners are at the forefront of, distributing COVID-19 vaccine to other parts, to Africa and other regions. Is WHO also in the forefront of pushing for vaccines, for other diseases that are endemic, not just, in Nigeria, but also in other parts of Africa? Ebola, for instance, we're talking about TB.
Right, like I said earlier, like we are finding out to end TB, you need vaccinations. We in WHO have said that. And that's why when you look at those strategies that I said, MTB strategies, the last strategies is talking about intensifying research, and vaccination is part of that, right? And that's why we are pushing that for this vaccine that I've told you about, that is in top phase, that by next year, hopefully it will be out, and then we can use it, especially in the sub-Saharan Africa, to prevent people from progressing from infection to disease. So WHO is working tirelessly in this area to ensure that vaccinations is available, because we cannot end tuberculosis, I can tell you, without having that vaccination, right? And like I said, it has reached the third phase. And from the third phase, it will be approved for use. Once it's approved for use, then we can use it in the country.
You expressed concern about Nigeria's ability to meet our target in 2022, and you gave the gaps. I'd like to take Dr. Anyike here. Are we likely to meet our target for 2022?
It's not likely we'll meet our target by the data we have. However, we have been able to come up with a national strategic plan, 2021 to 2025, which runs in accordance with our National Health Strategic Development Plan, Phase 2, and the WHO Stop TB Global Plan. So in that plan, all that we've discussed, even the awareness creation and others, are tabled down. Then the strategies of improving diagnosis and placing on treatment. The two things we must take away is, one, getting the infection, and two, treating the ones we've gotten to cut the chain of infection so that it does not keep, progressing in the communities. And also, ensuring that we put our efforts on the preventive measures. It's just like you come into your house, your room is flooded. The best thing to do is to put off the tap and use every other mechanism to mop up the floor. If you do not close the tap and you keep mopping the floor, you can do it for hundreds of years.
But WHO has a different advice. I know WHO is advising a change in approach so that the missing cases can be detected. What is your advice? What kind of approach does the WHO have in mind?
Okay, for the detection of the missing cases, one thing I like to say that we must have in mind is that for every case that is not detected that is infectious, is able to infect 12 to 15 people per year. And that's why the detection of that infectious cases is very, very important. We have also realized that limiting your service to the health facility alone cannot help you, right? Because most people will not come to health facility, right? No matter what you do, most people will not come to health facility. So you have to take your services to the community. So we are advising that we use two fronts. We intensify our cases in the health facility. We also intensify our action in the community. Take the diagnostic material to the community, right? Take your X-ray to the community, right? Increase awareness in the community. And that's what we did during this COVID. One of the things we did during this COVID, that we have this COVID lockdown. And that we have 15% increase in cases. Because services were taken to the community. We have community health workers in the community asking people, are you coughing? If you are coughing, you don't have to come. Just produce your symptom. I will take it for you. I will test you. I will do the testing. So these are some of the area we are looking at. We also look at area of integration, right? The area, if you look at tuberculosis cut across, right? So it's not a sector response. It has to be a multi-sectoral response, right? All the sector must be involved. If you only a sector that want to do it, we will not achieve it. And that's why we are helping the country to put a kind of a multi-sectoral framework that bring out all the ministries together, not only the Ministry of Agriculture, because they have a role to play, Ministry of Education, they have a role to play. There are countries where, from primary school, TB is in the school, is in material. People are educated about TB, so you know about TB even before you grow up.
What of making it a routine primary healthcare check, just as we did for HIV?
Yeah, and we have that's why I talk about intensifying in the health facility. What we are doing in the health facility is that if you enter in the health facility, in most of the health facility, they are going to ask you, are you coughing? Are you losing weight? Are you having fever? The aim why they are asking you is that they want to also know if you have TB. So we want to pick anyone that comes to the facility, pick them as early as possible. So we are doing what is called PQE. We call it PQE, Program Quality Efficiencies. That's what we call it.
All the things you're reading out they look strategic and real. But my concern is whether these things are practiced in Nigeria, are the health facilities available in Nigeria, and how do we know that they are being that those strategies are being applied? Because it's good on paper, right? But what about the implementation? Just like Professor Sadiq said earlier on, that when we have all these beautiful ideas and strategies, they're always beautiful on paper. But when it comes to the real implementation, we'll begin to have issues. So are these things you are rolling out being practiced in Nigeria?
Are they feasible? That's what this should be asked.
Yes, they are being practiced, and the only way you can know is by looking at the data. That's why if you look at our data is increasing. The detection of new cases is increasing, and we are working towards making sure we improve on that. 2012, we had just 3,000 and above. 2020 at end, we have 17,000. We have 138,000 new cases that we're able to detect, and those that if we place them on treatment, we may have cut off those 132,000, infecting more people. So the only way we can know is through our monitoring and evaluation and giving us the data, which is showing that there's an improvement.
Okay, let me take my last question from Professor Sadiq. Professor Sadiq, just a quick one now. Earlier on, you mentioned about gene expert machine, which I know is used for COVID-19 testing. Is it a positive coming out from COVID-19 era for TB detection?
Well, actually, Gene Expert Machine has been with us even before COVID-19 came into being. In fact, it is as a result of TB that we began to use it, and then its use even was extended to other diseases, for example, hepatitis, which affects the liver. But then with the coming of COVID-19, which is primarily tested with what we call PCR machine, and then it was discovered that you can even use the Gene Expert Machine to diagnose COVID-19. So we now have more Gene Expert machines because we want to use them for COVID-19 tests. But then the beautiful thing about it is that you can use it to diagnose TB. For example, in my center, we acquired one new Gene Expert machine primarily because of COVID. But then it has now been registered into the National Program on Tuberculosis, and we are now at the verge of start diagnosing, because the national program has taken it into their own system. I'm sure this will be applied in almost all parts of the country where you have the gene expert machine. So it's one of the positive things that we have as a result of the appearance of COVID-19 pandemic.
All right, we would like to thank you once again, Professor Sadiq Abubakar, for your contribution this morning on the program. But before we actually sign off our guests, Claire, it's good to appreciate the fact that some Nigerians actually made their own contributions via tweets. We had the Festus, Chris Simeon, Law Alpha, Mike, and others like Dele Jack Solomon, and many others who actually contributed to this conversation. Time will not allow us to go through all the tweets that we have this morning. So at this point, once again, let's appreciate Professor Sadiq Abubakar, Center for Infectious Disease Research, Bayero University, Kano, and a member of Kano State Task Force on COVID-19. Thank you indeed for being part of our show this morning. And Dr. Omoni Amos, National Professional Officer for TB and HIV World Health Organization. Thank you for coming. And again, we also like to appreciate Dr. Chukuma Anyike, Director and National Coordinator, National Tuberculosis and Leprosy Control Program, Federal Ministry of Health. We also thank you for coming. All right, at this point, let's take some sports news.
Leaders Nigeria insists they will go for 3 points when they come face-to-face with neighbors Benin Republic in Port